We are going to begin this plenary session under the heading, A Discussion about the Impact of the Economic Crisis and Proposals for Reform of Health Systems in Southern Europe. I am very honored to present you to leading economists. I admire both of them. I have with me Beatriz González, who is very well known by all of you, and Pedro Pita Barros from Portugal, also a very good friend and who comes frequently to our meetings. Well, you know, Beatriz is a professor at the University of Las Palmas. He got his PhD at the University of La Laguna. She's been director of the Department of Quantitative Methods at University of Las Palmas. She has had management responsibilities as Vice Rector for Economic Affairs in her university. She's been visiting professor at MIT, at Erasmus University, now at University Pompeu Fabra. She's been member of the Council of Advisors to the Health Ministry in Spain, consultant for many firms and for governments in regional and national governments. She's been president of the association also, and she has a long CV. She's one of the more productive health economists in Spain on quantitative methods applied to health economics, simulation models. He has worked on economics of smoking, human resources, drug utilization, new technologies and innovation, pharmaceutical pricing, a very distinguished record of contribution to health economics. And Pedro Pita is also a leading economist, very well known all over the world. He got his PhD at University. Now he was visiting professor at Universitat Autònoma de Barcelona. He was a member of the Committee on the Sustainability of the National Health Service in Portugal. He's a member of the Center for Economic Policy Research. He's been a member of the Committee for the Arrow Crisis, and his research is also very well known. He has applied industrial organization methods and concepts to health economics. He's been working on waiting lists, on the relation between private and public sectors, payment systems, insurance, medicines, and he has many publications and a very nice introductory manual on health economics also. They are going to discuss about the heading of this meeting, about crisis and austerity and horizons of health reform in Spain and in Portugal. And the session will take place as follows. They will first of all take the floor, each of them for 10-15 minutes. Then they are going to discuss and interact between them. And then we will have, I hope, time enough, perhaps half an hour or even a little more, for questions and discussion. I give the floor to Pedro. He's our invited speaker now. And then I will give the floor to Beatriz.
Okay, let's see if it's working. Yes. First of all, thank you, Felix, for the nice introduction. It's totally undeserved. I just happen to be here because I'm Portuguese. Portuguese is under austerity. That's basically the reason. It's a pleasure to address you. And we planned this session to have some interaction with the audience afterwards so that we can have questions and discuss a little bit all these issues. So if you don't have questions, don't worry. I have slides for 2 hours. And so if needed, I can keep going. So this is just to keep you on the mood to ask questions afterwards. So let me just go quickly on the context of Portugal. And something that will be important to have in mind, I think it's an important feature of the Portuguese situation right now, as I will try to describe, which is a memorandum of understanding. What does it mean? Portugal is under financial rescue since May 2011. And that meant that we had to get our public finance into shape, but under the strict observation from the Troika, which has signed this memorandum of understanding with the Portuguese government, which basically has commitments of the Portuguese government how to improve the financial situation of the government. Now, in this memorandum of understanding, we had in the beginning more than 50 measures related to healthcare. It's one of the major areas of intervention. And so they also have these quarterly reviews, which so far have been declared as okay, without major problems, except for the last one, which took longer. It's not yet finished in the sense that the report is published, but it was cleared anyway. And so we have now something that relates to these issues. So from these 50 measures that were supposed to take place in the period of 2 years, mostly of them in the period of 2 years, they go from the very detailed nature of some of them, something like they say, we have to reach 1% of GDP as a percent, well, public expenditure on pharmaceuticals needs to be 1% of GDP by the end of this year. This is a very clear target, right? And it has been some discussion of what is meant, what is inside public expenditure. It includes hospital expenditure, it includes ambulatory expenditure with pharmaceuticals. There's a huge fight about what is the precise meaning of the target, but there is a target. In other areas, it's much more diffuse what is the target. It says you need to get 200 million savings over 2 years in hospital working. It doesn't specify how to get there, what needs to be done. It's left to the country. So we have very detailed from to general purpose. What was there in the beginning was a strict timetable to implementation. Now, this is something that is curious as well, because from the strict timetable, we get some things that were along the way getting some flexibility. Some of the things were delayed, some of the things were removed, some of the things happened the way they were prescribed, some of the things didn't happen at all. And so even if we have this memorandum of understanding that creates a strict timetable, there is flexibility to change things along the way as long as you have a convincing argument to make it differently. Now, this touched almost every area of intervention in the public health sector. There's nothing in the public health sector that has not been touched by this memorandum of understanding. I don't have the time here to show you all the areas, so I aggregated the 50 measures into a smaller number of areas. If you want to see the full range of measures and how they evolve over time, I will be pleased to tell you later on. So there was user charges increases that were decreed in the beginning. And there were two things that were important in user charges. They said they need to increase the values, they need to differentiate between primary care and and hospital care, and they need to revise exemptions of people to these charges. There are certain exemptions, poor people, children under 13, and the other categories are exempted from the charges. Now, what happened with the Portuguese government? They did it very quickly. So the memorandum was out in May 2011. By the end of the year, all the measures were taken. January 2012, they started, as prescribed. What happened to user charges? They increased to the double, but they also increased the exemptions. And so you don't know to which side it goes. But if you want to say whether they complied with the measure, yes, they did. What are the effects? We can talk a bit later on this. Pharmaceutical market. Pharmaceutical market, they have a huge range of measures, ranging from retail distribution, where you have to have savings. If you are interested, just go back to the papers we presented yesterday. You have the abstracts there. That's one of the measures. You have the targets. Now, are the targets for public spending being complied with? Yes and no. That's an economist kind of answer, right? We always have yes and no. Here it's clear the yes and no. For 2012, they meet the target of having 1.25% of GDP in public expenditure of pharmaceuticals by setting an agreement with a payback system with the pharmaceutical industry. So if the target was not met, the pharmaceutical industry would pay back what was the difference. They met the target for ambulatory care, for the part of ambulatory care. They didn't met the target for hospital care. Pharmaceutical companies are being invoiced to pay back. Now, why then I say that it's not being met? Because with a payback mechanism, you don't change the underlying dynamics. So once the agreement is over, you're going to go back to the old spending levels. And so you are changing formally things, you are not changing the dynamic nature of things. So, but the measure was done. And actually, pharmaceutical market is giving you 30 to 40% of all the savings in public expenditure related to health. And total savings amount nowadays to 1.1 billion euros in a total budget of 7.5 billion, more or less. So it's a strong adjustment. And a lot of it is coming from a pharmaceutical one. They wanted to influence prescription patterns. They want to have a more rational prescription by physicians in both pharmaceuticals and laboratory exams and complementary tests. For that, they are creating national guidelines for best practice. Since September 2011, the Medical Association and the Portuguese government, with the Directorate General for Health, are actually working on these guidelines. Until the end of the year 2011, they published some of them with an impressive rhythm of publication. Then they slowed down. The question now is whether they are actually being implemented or not, and whether they are going to be audited. But if you want to measure this thing, this requisite, by saying, have they published guidelines to monitor what's going on? Yes, they have published guidelines. What is the major area of intervention here? Will be hospitals. Are hospitals monitoring the prescription patterns? Some of them, yes. They are giving feedback information to doctors, where they stand in a prescription pattern. They are asking to the ones that are high prescribers whether there is reason for that. And so there seems to be something happening there, so that's why I put there mostly done. Management of the NHS. Management of the NHS basically is this kind of things that we put there, everything that does not fit in any other categories, right? Which is broad management of the NHS. Well, here, one of the major things was hospital restructuring, meaning thinking about the hospital network and what makes sense in it. For example, we have one famous situation in Portugal near the River Tejo that we have 3 hospitals, relatively large, with 20 to 30 kilometers apart from each other, with a very small population. One hospital will be enough, and we have 3. The problem is that none of the municipalities accepts that its own hospital closes down. So they merge them into a single unit, and then they close services in one hospital, and they close services in another hospital. But basically, you have 3 hospitals that work like one hospital with 30 kilometers corridors. So patients have to be transferred from service to service. Okay? But there are other places in the country where you have these sorts of things, that you should start thinking about how to close down things. You have increase in day surgery. Day surgery means that you should close down things. In Lisbon, it opened a new hospital in the neighborhood, in the suburban area of Lisbon, that is capturing kind of 20 to 30% of activity of the largest hospital inside Lisbon. Nothing closed inside Lisbon. We had a decrease in the number of births in Lisbon in the last 10 years, about 30%. We opened a new maternity, and it didn't close anything so far. So we need to reorganize this hospital network. But basically, we don't see much happening there. It's mostly delayed. It's moving slowly in the sense there is a plan to restructure, but we don't see things happening. Primary care, it's, as you could expect, there is something in the memorandum that says we should develop more primary care. We should invest more in the small units that we have now, family health units, that seem to be working better than the traditional centers, but the rollout of it is slowing down. Why? Because the new family health units have a payment system where you pay by capitation, part of it, and then you have some incentive system on the side. But the government does not want to pay the incentive system because it says it has no money. So for the past guys that were entitled to receive some money under this incentive system, they were told, we're not going to pay you this year because we don't have money, and we're not going to allow new ones to have the new system. So that part is moving slowly. But at the same time, the government was able to get a deal with the medical unions, increasing the number of patients that can be in the list of a primary care doctor. So in a sense, they were able to open up the way to have more people treated. And so that's why I have there primary care, slowly moving on the organizational part, a high mark for the agreement with unions. Where is the risk now? Well, are they going to implement the agreement or not? And that's the typical problem that we're going to face, implementation of these issues. Human capital health and health professionals. This is one of my favorites in terms of process, because it was said that in 2 months